Hello, I am Rosalino Vázquez López, a researcher at the Universidad Anáhuac, Mexico. My team and I appreciate the invitation to this second edition of COVID-19 International Congress. One of my line of research that I have developed with my friend, Dr. Leonel Castro, is the study of the pathophysiology of SARS-CoV-2 infection. It is a pleasure for us to share today the presentation entitled Cardiovascular Complications after SARS-CoV-2 infection. Thank you.
As we all know, the infection by COVID-19 virus is responsible for generating an inflammatory disease with high levels of morbidity and mortality. This inflammation is accompanied by cardiovascular alterations such as arrhythmias, myocardial injury, acute myocardial infarction, and venous thromboembolism. The objective of this work is to shed light on these complications, describing them in depth, as we consider that it's vital for the entire medical community, from students to specialists, to understand the factors that can lead to such difficulties.
Coronaviruses are enveloped single-stranded positive-sense RNA viruses, composed of club chain glycoprotein spikes on their surface that mediate receptor binding at cell entry during infection. These spikes are its main morphological characteristic. They give it a crown appearance, the Latin term for crown being corona. They are the largest group of viruses belonging to the order Nidovirus, which includes the family Coronaviridae, Arteriviridae, Mesoniviridae, and Rhonaviridae. The Coronaviridae comprise one of two subfamilies of the Coronaviridae family. Coronaviruses possess an RNA genome that cause a broad spectrum of multisystemic diseases in birds and mammals, causing upper respiratory tract infections in chickens, including enteritis in pigs and cows, as well as life-threatening respiratory diseases in humans. Currently, 7 human coronaviruses have been identified, of which several cause common colds and self-limited upper respiratory infections. However, not less than 3 have caused widespread lethal outbreaks, including the highly pathogenic severe acute respiratory syndrome coronavirus SARS-CoV, the Middle East respiratory syndrome coronavirus MERS-CoV, and most recently SARS-CoV-2. Genomic studies show that SARS-CoV-2 likely originated and evolved from a strain found in bats. The main mechanism of exposure appears to be person to person, with symptomatic individuals being the most common source of spread. Although presymptomatic and asymptomatic individuals can be a significant source of this spread. Transmission is believed to occur through respiratory droplets that are spread by coughing, sneezing, or talking, although aerosol transmission is also possible in confined spaces. Studies reveal that SARS-CoV-2 could be found on objects or surfaces for hours and days. One study case found that virus on plastic and stainless steel for up to 2 to 3 days, on cardboard for up to 1 day, and copper for up to 4 hours. SARS-CoV-2 RNA has also been detected in blood and feces, although fecal oral transmission has not been documented, suggesting that the presence of the viral RNA doesn't necessarily establish that the virus is also viable and infectious. SARS-CoV-2 has a quick reaction to ultraviolet rays and heat, but the inactivation temperature needs to be studied further. These studies can be effectively neutralized by the use of lipid solvents, including either ethanol, chlorine-containing disinfectants, and peroxyaceric acid to get a better result. According to the clinical manifestations, the incubation period of COVID-19 is generally 14 days after exposure. In most cases, they occur an interval of 4 to 5 days after exposure. The spectrum of illness can range from asymptomatic infection to severe pneumonia with acute respiratory distress syndrome and death. The most common symptoms are fever, dry cough, shortness of breath, and gastrointestinal and other symptoms such as abdominal pain, diarrhea, anorexia, vomiting, myalgia, headache, dizziness, anosmia, dysgeusia, sore throat, fatigue, and chills. Mild pneumonia has also been reported.
Acute cause and complications. Some patients with initially non-severe symptoms may progress over the course of a week. In severe cases, there has been observed respiratory failure, cardiac and cardiovascular complications, thromboembolic infections, neurological complications, and severe inflammation. These can occur even in secondary infections. Thrombotic aberration in COVID-19 patients is common and appears to contribute to organ failure and death. Platelet hyperactivity, which is recognized in COVID-19, also contributes to morbidity throughout increased platelet-platelet and platelet-leukocyte interactions. Hemostatic alterations that mimic disseminated intravascular coagulopathy associated with sepsis often present with severe COVID-19 illness, with an elevated risk of thrombosis rather than bleeding. Most children with COVID-19 present either without symptoms or with symptoms milder than in adults. Symptoms resemble routine acute chest infection with pyrexia, dry cough, sore throat, sneezing, myalgia, and lethargy. Less commonly, wheezing, diarrhea, and vomiting have also been noted. Multisystem inflammatory syndrome, an uncommon disorder in children, has also been associated with SARS-CoV-2, resulting in severe illness in previous healthy children and adolescents. Some patients who have recovered from COVID-19 have persistently or recurrently positive nucleic acid amplification tests, also known as NATs, for SARS-CoV-2. Although recurring infection or reinfection cannot be definitely ruled out in these settings, evidence suggests that these are unlikely.
When comparing different studies, we found that cardiovascular complications as a consequence of a COVID-19 infection are not uncommon. As mentioned before, these include arrhythmias, fulminant myocarditis, heart failure, and myocardial infarction. In this section, we will review some cases that have reported cardiovascular complications as a consequence of COVID-19 infection. Our first case of interest is a 63-year-old male patient with symptoms characteristic of COVID-19 infection, with no history of cardiovascular disease. This patient underwent different tests which show an increase in elements such as troponin 1, myoglobin, and the N-terminal brain natriuretic peptide. An electrocardiogram was performed, in which sinus tachycardia was found without ST segment elevation. Other cardiac findings were left ventricular hypertrophy, diffuse myocardial diakinesis, pulmonary hypertension, and an integral right heart function. This patient met all the criteria for fulminant myocarditis, such as sudden onset, symptoms of viral infection, severe hemodynamic disturbances, severe myocardial injury, and decreased ventricular wall motion. Our second case was a 53-year-old woman who presented to the emergency room with signs and symptoms characteristic of the infection in question. This was confirmed with a polymerase chain reaction, or PCR. Her electrocardiogram showed diffuse ST segment elevation. Also, high levels of high-sensitivity troponin T, NT-pro, and BNP were detected. Increased wall thickness with diffuse biventricular hypokinesis and severe left ventricular dysfunction were reported. Biventricular myocardial interstitial edema and diffuse late gadolinium enhancement were also found, affecting the entire biventricular wall. Pericardial effusion was found. All of these findings are compatible with acute myocarditis. Our last case is about a 61-year-old male patient who was hospitalized after presenting several symptoms of the infection in question. A blood sample was taken, and 12 hours later, the laboratory reported that the patient presented signs of leukocytosis, lymphopenia, and an elevation in the high-sensitivity troponin 1. Also, liver function and renal function were presented alterations, and there was mild hypothermia. An electrocardiogram was performed and showed sinus rhythm with an ischemic wall, left axis deviation, and left ventricular hypertrophy. Severe mitral regurgitations, left dilatation of the heart and right atrium, and moderate aortic regurgitation. All of these signs spoke of acute decompensated heart failure. Although all patients and all cases are different, The common factor for most severe cases is increase in high sensitivity troponin 1, as well as unusual electrocardiographic data, liver and kidney failure. To conclude this section, it is important to mention that the article's review highlighted the need for further research of these patients.
Coming up next, the pathophysiology of cardiac complications. The acute progression of the disease is divided into three phases: the early infection phase, the pulmonary phase, and the severe hyperinflammation phase, with a rate of 81% of symptomatic cases. During the early infection, the virus begins to enter the pulmonary parenchyma, where it starts to proliferate without any problem, characterized by a mild constitutional symptoms, marking the initial response of innate immunity, specifically of monocytes and macrophages, creating an inflammatory processes such as the vasodilatation, endothelial permeability, and leukocyte recruitment, leading the patient through a path that would have hypoxia and cardiac stress as a destination. All this systemic toxicity can even damage distant and adjacent organs, such as the case of myocarditis in patients with COVID-19 who have no evidence of direct viral infiltration, generating systemic inflammation to cardiac tissue. Lymphocytopenia also takes a role of importance during the analysis of the patient's signs and symptoms, providing adverse results demonstrating that a higher percentage of non-survivors and COVID-19 patients present this fear of progression. However, despite the decrease of lymphocytes in the blood, patients develop, on the other hand, larger numbers of leukocytes and neutrophils, suggesting a capacity to infect indirectly by leukocytes, which harbor more than 50% of viral particles, most of them being T lymphocytes. Both CD4 and CD8 T lymphocytes were found to be low, which is also due to the low levels of regulatory T cells, the main agents of T cell homeostatic regulation. That said, we can analyze the viral spread that COVID-19 has, which starts in the lungs, spreading with an amplified inflammatory response to the other organs, such as the heart. According to these statements, biomarkers and electrocardiogram abnormalities are correlated with elevated inflammation markers, leading us to the main point of the article: the indirect mechanism of cardiac injury. Angiotensin converting enzyme 2, also known as ACE2, is the protagonist of this article. Here we can see it's the target cell of the virus. ACE2 is a carboxypeptidase that converts angiotensin 2 to angiotensin. This enzyme is homologous to the angiotensin converting enzyme, also known as ACE, but plays a counterbalancing role in the renin-angiotensin-aldosterone system, also known as RAS. Beyond its role in the cardiovascular homeostasis, ACE2 is also a functional receptor and a portal of entry for SARS-CoV-2 and SARS-CoV. ACE2 is also expressed in multiple tissues, including the lungs, heart, and kidneys. In animal models, ACE2 expression in the heart is an essential regulator of cardiac dysfunction, as it is one that decides and allows the creation of angiotensin, leading to increased constriction and consequently much higher pressures. Because of this, studies were performed in test animals in laboratories, these being mice. As a result, mice without ACE2 can develop severe left ventricular dysfunction. SARS-CoV infections appears to downregulate ACE2, which may contribute to the myocardial dysfunction. Thus, the relationship between SARS-CoV-2 and ACE, providing a theoretical mechanism for cardiac dysfunction in COVID-19 downregulation of ACE2. Moreover, the relationship between virus entry and ACE2 forms the basis of the controversy surrounding the use of RAS antagonists, which function to increase ACE2 expression and thus can theoretically increase susceptibility to the infection. But even the direction of the effects is disputed. Levels of ACE2 may be protective by providing a reserve of receptors to compensate for those lost in the infection. However, there is no convincing data in humans yet. So like that, we can conclude the pathophysiology of cardiac complications.
Hi, I am Dr. Lionel Castro, researcher from Anáhuac University, and I will tell you the conclusion. Cardiovascular complications after SARS-CoV-2 infection are of great relevance since the chronic sequelae are poorly known. These comorbidities may increase the risk of individuals who have already been cured by the infection. This systematic review pretends to open a research line that physicians can study. However, many remain unknown. Here you may see the sources that we used for this review. On behalf of the team and the Anáhuac University, I would like to thank you for your time. We hope you find this review useful. Regards from Mexico City, and see you soon. Goodbye.